Dr. Shira, ilan tayo sa
Good morning po, Doc. According to the latest list for 107 po, Doc.
morning? Ilan yung official list?
Doc, i-forward ko po sa inyo.
Anyway, let's start. I'll just take a screenshot of everyone present. Can you turn on your cameras? Okay. Okay, let's start. Okay, can you see my screen?
Yes po, Doc.
Okay. So, good morning. This is actually basically a boring topic as we will be discussing about your melanocytic lesions, your hair and nails. This also includes the continuation of your tumors from your last topic, and I just made it more visual so you would appreciate the morphology of the lesions more. So no need to screenshot. I'll be giving the copy of this after our lecture. So right now we move on to our melanocytic lesions. So basically, we have your epidermal melanocytic lesions, your dermal melanocytic lesions, and of course, we will also tackle your melanoma and those with malignant degeneration. So it is important to note that your melanocytes originate in the intramural crest and migrate to the epidermis, your dermis, your leptomeninges, your retina, your mucous membrane epithelium, your inner ear, your cochlea, and your vestibular system. So, when you request for your immunohistochemical stains for your melanocytic lesions, you actually request for your S100, your HNB45, your Melan A, your MARC1, your MITF, and your subset. So, not only for your epidermal melanocytic lesion, but your melanocytic lesions in general. So first is we discuss the type of your epidermal melanocytic lesions. So we have your epidermis or the common freckle. It occurs in your light-skinned individuals in response to your sun exposure. And histologically, your freckles demonstrate pigmented basilar keratinocytes and the mild increase in the number of your melanocytes, whereas your nevus pigos, we also call it your speckled lentiginous nevus. They present as a light brown or tan macule, speckled with your smaller, darker macules or papules, as seen in the picture. So both of these can be treated with your QS or your Q-switch lasers, which targets your melanosome. You can also intervene with your lasers with longer pulse duration, resulting in your melanocyte destruction. And we can also consider giving your lightening creams, but the response is actually not good for your nose creams. Another is your Lentigo Simplex. So these lesions occur as sharply defined round to oval brown or black macules, and usually they arise in childhood but may appear at any age. So there is no predilection for areas of sun exposure, and histologically you would actually note hyperpigmented basilar keratinocytes and increased in your melanocytes in the basal layer. For your solar lentigo, we also call this as your liver spots. These are persistent, benign, discrete, hyperpigmented, round to oval macules occurring on sun-damaged skin. So take note that your solar lentigo occurs on sun-damaged skin, while as for your lentigo simplex, there is no predilection. So on histology, you would actually note that there is a club shape or narrow bud-like extensions of your red ridges as seen here. And of course, there is increased pigmentation in your basal cell layer, especially at the tips of the bulbous here. So for your treatment, we usually advise application of your liquid nitrogen with a cotton tip applicator or cryospray. And then we can also advise your laser treatments as well as your bleaching creams containing your hydroquinone, tretinoin, and other includes your adapalene. So next is your covalent hinges or your treatment with your Sorolin plus your ultraviolet A treated uh, given in patients with psoriasis, mycosis fungoides, etc. So these individuals usually receive your oral methoxylin photochemotherapy, and patients develop lesions occurring at the sites that are normally protected from the sunlight due to high dose single exposure to your patient. So we also have your ink spot lentigo, which is your sunburn lentigo, occurring on the shoulders as small, extremely irregular reticulated dark gray to black macules resembling spots of ink on the skin. So as for these lesions, they can also be noted with their different syndromes, including your leopard syndrome and Hughes-Jaeger syndrome. So for your leopard syndrome, it is actually autosomal dominant, and uh, this is actually a mnemonic acronym for your LEOPARD. So we have your lentiges, your electrocardiographic abnormalities, your ocular hypotenderism, pulmonary stenosis, abnormalities of your genitalia, retardation, and deafness. And it is associated with your PTPN11 gene mutations, which can also be seen in patients with Melanoma syndrome. Another is your Hughes-Jaeger syndrome, which is also autosomal dominant, with pigmented macules on the lips, oral mucosa, and perioral and apical areas. So your GI polyps may be prominent in jejunum. Another type is your Becker nevus, presenting as hyperpigmented hypertrichotic patch on the upper trunk or your proximal upper extremity, usually seen before puberty, and almost all patients are males, and is typically associated with your smooth muscle hamartoma, while your melanoacanthoma, so this can be seen on the skin, and your differential diagnosis for your melanoacanthoma may be your pigmented seborrheic keratosis, as seen here, or your pigmented BCC. However, it can also be seen on your mucosal area. So we also have your oral melanoma. As for the treatment for your Becker nevus, it may not be necessary, but some patients desire removal of pigment or terminal hair associated with lesion. So we do your ablative fractional laser and hair removal laser therapy. We can also give your topical flutamide, while for your melanoacanthoma, these are usually has a rapid onset and spontaneous resolution are typical. So we move on to your benign melanocytic nevi. So in general, features of your benign nevi include a diameter of less than 6 millimeters with perfectly uniform pigmentation, flaccid epidermis, smooth uniform border, and unchanging size and color. However, take note of your eruptive nevi, which can be seen in association with your bullous diseases, severe sunburn, immunosuppression, or sulfur mustard exposure. So we have three types. You have your junctional, your compound, and your intradermal. So for your junctional nevi, these are usually flat. So we have your sharply circumscribed brown macules, varying in diameter from 1 to 6 millimeters, while your compound nevi actually demonstrate both your junctional and your intradermal size. So for your compound nevi, these are usually elevated lesions, while for your intradermal nevi, these are actually generally smaller than your junctional nevi. On histology, you would note that the presence of melanocytic nests in your junctional nevi is confined only to your epidermis for your compound nevi. So a combination of your nest on your epidermis and dermis, while pag intradermal, confined to the dermis na lang yung natin. So actually almost half of our melanomas occur in pre-existing nevi, and an increased number of nevi represents a risk factor for your melanoma. So the signs of your malignant transformation in pigmented nevi are recent enlargement, irregular or scalloped border. There is asymmetry with changes or variegation in color, especially red, white, or blue. So surface changes. So they're usually are scaling, erosion, oozing, crusting, ulceration, or bleeding. So we also have development of impalpable thickening, signs of inflammation, or the appearance of your satellite pigmentation. So we can have your pseudomelanoma. Another term is your recurrent nebulous. So we also have your balloon cell nevi, which are actually indistinguishable from your ordinary clinical. And we also have your halo nevus, also known as your total nevus or perinevoid vitiligo. Also your leukoderma, acquisitive centrifugal. And these are pigmented nevus with a surrounding depigmented. So we also have your giant congenital melanocytic nevus, or sometimes they are your giant pigmented nevi. So they appear as your large, darkly pigmented hairy patches in which smaller, darker patches may be interspersed or present as small satellites. So we also have your Spitz nevus. Clinically, you would note a pink, smooth surface, raised round firm papules. Of course, your differential for this may be your intradermal melanocytic nevi. However, on histology, you would note the presence of your camino bodies or your dull pink globules seen in the epidermis. So another is your dysplastic nevus. So other term is your atypical nevus or your Clark nevus, which presents as a variegated tan, brown, and pink coloration, mainly in the macular portion. So when you have your dysplastic nevus and you have a family history of melanoma, or at least you have two blood relatives with your dysplastic nevus, you have a 100% lifetime risk of acquiring your melanoma. So we proceed to your dermal melanocytic lesions. So we have your dermal melanocytosis, known as your Mongolian spot. And on morphology, you would note a bluish gray macule that varies in diameter from 2 to 8 centimeters, occurring typically in the sacral region of the mother. And on histology, you would actually note that the Mongolian spot shows your elongated dendritic dermal melanocytes widely scattered among normal collagen bundles in the deep dermis. So, so take note that your dendritic dermal melanocytes are noted in your deep dermis, while for your nevus of Otta, known as oculodermal melanocytosis, you would note that your dendritic dermal melanocytes are scattered in the upper portion of the dermis. So your nevus of Otta and your nevus of Iku are actually they actually have the same features. However, for of course the distribution and the area of involvement is different. So for your nevus of Otta, you actually see this on the ocular area, while for your nevus of Iku, you would actually see this on the posterior, supraclavicular, and lateral cutaneous brachial nerves involving your shoulder, side of the neck, and your supraclavicular areas. So difference is the location of your dendritic dermal melanocytes. Again, for your dermal melanocytosis, usually it is located in the deep dermis, while for your nevus of Otta and nevus of it is seen scattered in the upper portion of your dermis. So another is your blue nevus. So in general, these are well-defined blue papules and nodules. So we have your blue nevus or common blue nevus. We have your cellular blue nevus, most frequently seen on the buttocks and sacrophysian region. We also have your epithelioid blue nevus, your deep penetrating nevus, your amelanotic blue nevus, and your malignant blue nevus. So for your blue nevus, So all of this except your epithelioid and some of your cellular blue nevi are associated with a dense sclerotic stroma. And for the treatment, excision is the mainstay. However, there is reported success for your QS ruby laser for patients given intratumoral interferon beta therapy, and for blue nevus with your malignant variety, treatment is same with your melanoma. So we move on to your malignant melanoma. So your ABCD criteria actually helpful for the detection of your melanoma. So the letters stand for A for asymmetry, B for border irregularity, C for your color variegation, and D is for your diameter, which is more than 6 millimeters. So take note of the ABCD of your ABCD criteria for your melanoma. Etiologic factors for melanoma include your light complexion, light eyes, those with blonde or red hair, those who have sunburns in childhood, heavy freckling, those with more than 50 benign nevi, or with clinical or histologic atypical nevi or dysplasia nevi, family history of melanoma, and those with mutations in your BRAF gene, KIT gene, and amplifications in your cyclin D1 and CD24 gene. So, melanoma types include your lentigo maligna, your superficial spreading melanoma, your acral lentiginous melanoma, your mucosal melanoma, nodular melanoma, polypoid melanoma, desmoplastic melanoma, and your amelanotic melanoma, as well as your soft tissue melanoma, clear sensor. So these are the different types of your melanoma. So we have your lentigo maligna, which begins as a tan macule extending peripherally with gradual uneven darkening over the years. So it is more common in older patients with heavily sun-damaged skin and those in sunny climates. So right now, it is the most common form of your melanoma. So before it is superficial spreading melanoma, but according to your textbook, your lentigo maligna is the most common type of, or most common form of melanoma. Next is your superficial spreading melanoma. So this was once the most common form of your melanoma, affecting adults of all ages, especially those in the fifth decade of life. So unlike your lentigo maligna, it occurs most often on intermittently sun-exposed areas. So difference is lentigo maligna is seen in those with heavily sun-damaged skin, while for your superficial spreading melanoma, this is seen in patients with intermittent sun exposure. This can also arise de novo or in association with your pre-existing adhesions. Another type is your acral lentiginous melanoma, which is actually the most common type of melanoma in dark-skinned and Asian populations. So, other types include your amelanotic melanoma, which can actually also be identified as your intradermal melanocytic nevi because of the morphology of the condition. So we also have other types include your nodular melanoma, your mucosal melanoma, etc. So we also have your desmoplastic melanoma here, So this is your deeply infiltrating type of your melanoma, usually having a spindle cell pattern histologically. And as for these types of melanoma, diagnosis is through your biopsy. So we advise complete removal of the lesion with a 1 to 3 millimeter margin of the skin. So this is the preferred method of biopsy. So kung nakinig kayo dito sa slide na to, I think may 5 points na kayo sa exam. Anyway, for the treatment, early excision remains the most important determinant. And for your sentinel node biopsy, this should be discussed with patients whose melanomas are 0.8 to 1 millimeter or greater in thickness. So we consider this for thinner lesions in patients who have ulceration, dermal mitosis, or other features of a vertical root face. So we can also advise imatinib, ipilimumab, and nivolumab, pembrolizumab, femoral in treatment your later stages of melanoma. So as for the margin, a margin of 0.5 centimeters is currently recommended for excision of a patient with a melanoma in situ, and then a 1 centimeter margin is recommended for your superficial spreading melanomas, and then 1 to 2 centimeter margin for those with less than 2 millimeter thick lesion, and 2 centimeter margin for those with more than 2 millimeter. So your most micrographic surgery can be useful in settings where there is asymmetric standard margin that does disservice to our patients. So this can also be advised in patients with lentigo maligna, those with mucosal melanoma, and your acral lentiginous melanoma, as well as with subclinical extension of the inside group. So we move on to the diseases of your skin appendages. So first is your hair diseases. So concepts to remember for your hair cycle is that normal human hairs can be classified according to the cyclic phases of growth. So we have your anagen hairs or your growing hairs. We also have your catagen hairs or those who are undergoing transition from the growing to the resting stage. And of course, we have your telogen hairs. So these are your resting hairs, which remains in the follicle for variable periods before they. We also have your tenogen, which is the lag period between the loss of your telogen hair and the growth of your new anagen hair. So we have your tenogen hair. So the scalp normally contains an estimated 100,000 hairs, and the average number of hairs shed daily is 100 to 150. The hair growth rate of terminal hairs is about 0.37 millimeters per day, and contrary to popular belief, neither shaving nor menstruation has any effect on your hair growth rate. The average uncut scalp hair length is estimated to be 25 to 100 centimeters, although exceptional hairs may be as long as 170 centimeters or 70 inches. So types of your alopecia include your non-cicatricial alopecia and your cicatricial alopecia. However, we will be focusing more on your non-cicatricial alopecia. So first is your alopecia areata, which is characterized by your rapid and complete loss of hair in one or more round or oval patches typically 1 to 5 centimeters in diameter, usually on the scalp, bearded areas, eyebrows, eyelashes, and less frequently on other hairy areas of the body. So your complete loss of scalp hair is referred to as your alopecia totalis, and complete loss of all hair is your alopecia universalis. So clues to diagnosis is your periodic regrowth, nail pitting, tapered hair fractures, exclamation point hairs, and it is usually associated with autoimmune destruction of your hair follicle. So treatment includes your IL steroid injection, which is the treatment of choice. So we can also induce your contact sensitivity, phototherapy, give cyclosporine, topical minoxidil, and laser therapy. So predictors of poor prognosis are the presence of your atopic dermatitis, childhood onset, psoriasis, duration of longer than 5 years, and onychodystrophy. So acute diffuse and total alopecia is newly defined subtype of your alopecia areata occurring in young adults with a good prognosis. Next is your telogen effluvium. So it presents with excessive shedding of normal telogen club hairs, and this excessive shedding of telogen hairs most often occurs 3 to 5 months after the premature conversion of many anagen hairs to telogen hairs induced by surgery, parturition, fever, drugs, dieting, or correction. So it is important that you consider months of history and predisposing factors or triggers before the onset of your telogen effluvium. So uh, your telogen shed may be estimated by your pull test. So we perform your hair pull test by grasping 40 hairs firmly between your thumb and forefinger, followed by a slow pull that causes minimal discomfort to the patient. So a count of more than 4 to 6 club hairs is abnormal, but the result can also be influenced by recent shampooing, combing, etc. So other tests include your clip test and your trichogram evaluation. Next is your male pattern baldness or your common baldness. So usually these patients have a predilection to the vertex and frontotemporal regions, and the presence of your whisker or your kinky hair may be the first sign of your impending male pattern alopecia. So treatment includes your minoxidil, your finasteride, and your dutasteride. So moving on, you also have your trichotillomania. So this is usually seen in patients with your obsessive compulsive disorder, depression, or anxiety disorders. So your trichotillomania is the compulsive practice of plucking hair from the scalp, brows, or eyelashes, and typical areas are irregular patches of alopecia that contain hairs of varying length, and the scalp has a short texture resulting from the short remnants of your broken up hairs. So these are seen in girls younger than 10, although boys and adults may engage in the practices. So treatment includes your behavior modification, psychotherapy, and appropriate psychopharmacologic medication such as giving your clomipramine and olanzapine. So other forms of your alopecia include traction alopecia and your pressure alopecia. So for your traction alopecia, this occurs mainly due to the prolonged tension of the hair, either from wearing the hair tightly braided or in a ponytail, or pulling the hair to straighten it, or rolling curlers too tightly, or from the habit of twisting the hairs with the fingers. So your traction alopecia most often involves the periphery of the scalp, especially the temples and above the ears, but a fringe of hair is characteristically present at the frontal and temporal hair. So another is your pressure alopecia. It occurs after prolonged exposure on the scalp and in patients with chronically ill in persons who are chronically ill after prolonged bed rest in one position. So other disorders include your hair structural defects, including your hair casts, Ilitorti, your Trichorexis nodosa, your Trichorexis invaginata, and your Moniletics. So for your hair casts or your pseudomeats, these are usually remnants of the inner outer sheath and may mimic meats in the scalp. Another is your Trichorexis nodosa, in which the affected hair shafts fracture easily and may have small white nodes arranged at irregular intervals. So, for your Trichorexis nodosa, usually these are your split ends. Another is your Trichorexis invaginata, also known as your bamboo hair, or your ball and socket deformity, or your wolf hair. So this is caused by the intussusception of the hair shaft at the zone where keratinization begins. These are also seen in patients with Netherton syndrome. Next is your Pili-torti, which is also known as your twisted hair. So this is a malformation of the hair characterized by twisting of the hair shaft on its own axis. So the hair shaft is segmentally thickened and light and dark segments are seen. Your scalp hair, your eyebrows, and your eyelashes will be affected. And your hair usually brittle and is easily broken. We also have your moniletics, also known as your beaded hair. So this is a rare hereditary disease characterized by dryness, fragility, and sparseness of the scalp hair with fusiform or spindle-shaped swellings of the hair shaft separated by narrow atrophic segments. Another is your hypertrichosis, which is an overgrowth of hair not localized to the androgen-dependent areas of the skin, and several forms exist. Many are induced by your medications, including your minoxidil, your cyclosporine, and your efalizumab. The excessive hair growth can be managed with bleaching, with creaming, shaving, locking, waxing, chemical depilatories, and electrosurgical ablation. So this can also be treated with your long falls NDIAG, diode, ruby, and long and short falls Alexandritis. Another is your hirsutism, which is an excess of your terminal hair growth in women in a pattern more typical of men. So just for the pointers sa hair diseases, again, you have your alopecia areata, which is a rapid and complete loss of hair on scalp, hairy areas with tapered fracture and exclamation point hair. That is usually due to the hair miniaturization from the conversion of your anagen to telogen. And on histology, you would actually note a swarm of these appearance. So as compared with your telogen effluvium, so you would notice a depigmented club-shaped bulb and will lack a sheath. Also, you would notice trichotillomania. So again, this is actually due to a shedding of your hair, of your telogen hairs, which may be due to baby surgery, fever, crash diet, traction, etc. So important that you note the triggering factors 3 to 5 months after you notice your before you note your shedding. Then last is your male pattern baldness, which is also your androgenetic alopecia, and you take note of your whisker or kinky hair, which can be the first sign of your male pattern alopecia. So we can have your male pattern baldness or your female pattern. These are actually distribution. The areas with a loss of hair. So we have your Hamilton Norwood classification for men and your Ludwig pattern appearance for women. And then again, the difference between your hypertrichosis and your hirsutism. So for your hypertrichosis, again, these are overgrowth of hair, not localized to the androgen-dependent areas of the skin, while for your hirsutism, these are actually noted on androgen-dependent growth areas, such as your upper lips, which is the most common, your cheeks, your chin, central chest, breasts. So when we see a patient with hirsutism, usually advise them on their tops, especially your people's wear tops. So we move on to your sweat gland disorders. So we have your hyperhidrosis, anhidrosis, and hypohidrosis, bromhidrosis, and bromhidrosis. So hyperhidrosis is your excessive sweating. So this may be localized to one or several areas, or they can be more generalized. So those with hydrosis localized to the palms, soles, and axilla, your palmoplantar hyperhidrosis. So this can worsen during warm temperature, and for the involvement of your soles, usually these are associated with your repeated keratolysis. For your gustatory hyperhidrosis, so this may be idiopathic or may be caused by your hyperactivity of sympathetic nerves, sensory neuropathy, parotitis, parotid abscess, and surgery or injury to the parotid, which is also known as your Free syndrome. So your febrile diseases, vigorous exercise, or a hot, humid environment may induce your generalized hyperhidrosis. Hyperthyroidism, acromegaly, DM, pheochromocytoma, hypoglycemia, salicylism, substance abuse, lymphoma, carcinoid syndrome, pregnancy, and menopause may also produce your generalized hyperhidrosis. And drugs such as anti-cholinesterases, antidepressants of the SSRA or TCA, so anti-glaucoma, bladder stimulants, opioids, and cyanodogs may cause hyperhidrosis. Treatment include your topical aluminum chloride, your Psoriasis, your Botox or your botulinum toxin injection, your anticholinergic agents, and your surgical resection. So next is your anhydrosis. So when we say anhydrosis, it is the absence of sweating, while your hypohidrosis is your reduced sweating. So this may be localized or generalized. As for your generalized anhydrosis, it mainly occurs in patients with ectodermal dysplasia, miliaria profunda, Sjogren's syndrome, Fabry, etc. And those uh, many drugs that causes your hypohidrosis are the following. So your anhydrosis or hypohidrosis is a dysfunction in any step in the normal physiologic process. Next is your bromhidrosis, which is also known as your fetid sweat or osmidrosis, or your malodorous sweat. So this is chiefly encountered in your axilla and your bacterial decomposition of apocrine sweat producing fatty acids with distinctive offensive odors is considered to be cause. So treatment for your bromhidrosis includes careful washing with antibacterial soap and use of dusting powders on the feet. So these are actually useful in eliminating your bromhidrosis. So we can also use your topical antibiotics such as clindamycin, which can be beneficial. So we can also advise your Botox. For your bromhidrosis, these are actually your colored sweat. So these are rare functional disorder of your apocrine sweat glands, frequently localized to the face or axilla, and it has been less noted in the abdomen, on the chest, in the breast, thighs, and lower arms. So the colored sweat may be yellow, which is the most common, blue, green, or black, and your colored apocrine sweat fluoresces and is caused by your liposuction. So treatment includes your Botox and your topical toxins. So we move on to your nail diseases. So we have different nail structural diseases, and we start off with your psoriatic nails. So for your nail involvement in patients with psoriasis is actually common with incidence varying from 10 10 to 78%. And the nail plate may have your nail pits, can also have your furrows or transverse depressions, also known as your boost line, which we'll be discussing later. So crumbling nail plate, you can also have your leukonychia, your splinter hemorrhages, and in your hyponychium, you would actually note some subungual hyperkeratosis, your oil spots, your yellowish green discoloration, and your onychosis. So for your lichen planus, we can actually note the presence of your iridium, which is your irregular longitudinal grooving and bleaching of the nail plate. So patients with lichen planus of males may present with thinning of the nail plate, shedding of the nail plate with atrophy of the nail bed, subungual keratosis, so onychopapilloma, erythrometia, subungual hyperpigmentation, and nail nebulous. So if all the nails are affected, we call that 20 nail dystrophy, or your draconychia, which can be the sole manifestation of your nails. Next is your clubbing. So it is divided into two types. We have your idiopathic and acquired, your secondary. So these changes occur not only in the nails but also in your terminal phalanges. So, for your clubbing, usually the angle formed by the dorsal surface of the distal phalanx and the nail plate is known as your Ingriban's angle. So normally, it is approximately 160 degrees. However, when you have clubbing, this angle is actually obliterated and it becomes more than 180 degrees or greater. So, for patients who have clubbing, you would not appreciate a diamond-shaped windows when the dorsal surfaces of the corresponding finger of each hand are seen in this picture. So, these are actually maybe secondary to pulmonary, cardiac, thyroid, hepatic, GI diseases. Next is your coilonephria, which we also know as your spoon nails. So these are thin and pointy nails with the edges everted so that if we drop of if a drop of water were placed on the nail, it would actually not run out. So for your coilonephria, it may result from your faulty iron metabolism and is one of the signs of your Plummer-Vinson syndrome as well as your hemochromatosis. As for your draconychia, the nails become opalescent, thin, dull, fragile, and finally reach longitudinal. So again, as mentioned a while ago, some lichen planus of the nails, when it involves all 20 nails, it is referred to as your 20 nail dystrophy. So this has been reported in patients with associated autoimmune processes such as your selective IgA deficiency, vitiligo, sarcoidosis, and your graft versus host disease. And your tazarotene or in combination with your topical corticosteroids may improve your treatment. Another is your onychosis. These are nails that are thickened but without deformity, while your Nico Cryptosis resembles your claws, or when you see it, or you describe it as a ram's appearance. So these are most commonly seen in elderly patients and may be caused by trauma or peripheral vascular disorders, but is most often caused by neglect or failure to cut the nails for very long periods. So we also have your onychocytosis. These are a common finding in the elderly population, and it is a localized or diffuse hyperkeratotic tissues that develop on the lateral or proximal nail folds within the space between the nail folds and the nail bed. It may involve the subungual area as a direct result of repeated minor trauma, and most frequently affects the first and fifth toes. And the use of your comfortable shoes should be encouraged. Next is your anonychia, which is absence of the nails, and this is a rare anomaly and may be the result of a congenital ectodermal defect or ichthyosis or your severe infection, prenatal phenytoin exposure, severe allergic contact dermatitis, and self-inflicted trauma. Also, it can also be caused by your Raynaud phenomenon, your lichen planus, your EB, or your epidermolysis bullosa, and severe exfoliative diseases. So, in patients with SJS or your Steven-Johnson syndrome, anonychia, a permanent anonychia has been reported as a complication. So, before we proceed, can we have a 5-minute break now? I'll be back 11:17. Thank you. Let's proceed. So we also have your onycho atrophy, which is due to the faulty underdevelopment of the nail, and this may be congenital or acquired. So the nails are thin and small, as seen, and your vascular disturbances, as well as your epidermolysis bullosa, lichen planus, Darie's disease, Hansen's disease. So this may also cause your onycho atrophy. For your onychomadesis, this is a periodic idiopathic shedding of proximal nail, and this is usually seen in patients with hand-foot-mouth disease, those with neurologic disorders, those on peritoneal dialysis, those with cutaneous T-cell lymphoma, pemphigus vulgaris, Kawasaki disease, allergies, varicella infection, etc. So, medications such as your azithromycin, retinoids may also cause your onychomadesis. So, for your use line, these are transverse furrows that begin in the matrix and progress distally as the nail moves. They are ascribed to the temporary arrest of function of the nail matrix, and although usually found to be bilateral, unilateral views line may also result from your systemic illness or major injury, such as your broken. For your half and half nails, they show a proximal portion of the nail white and distal half red, seen in the picture. So, about 76% of hemodialysis patients and 56% of renal transplant patients have at least one type of your nail abnormality. So, and your half and half nails are the most common. So your Merck's line is described as a narrow white transverse band occurring in pairs as a sign of your chronic hypoalbuminemia. While your Terry's line is associated with your cirrhosis, congestive heart disease, DM, and your geriatric patients. So as you can see, so the distal 1 to 2 millimeters of the nail shows a normal pink color, whereas the entire nail plate or proximal end has a white thickness. This may be due to the telangiectasias of the nail. So other nail disorders are your Meese line, which are white transverse bands, which is a sign of your inorganic arsenic poisoning. However, they are also reported in thallium poisoning, in your septicemia, dissecting aortic aneurysm, parasitic infections, chemotherapy, and both acute and chronic pain. So next is your hangnails, which is an overextension of your cuticle or your eponychium, which becomes split and peels away from the proximal and your lateral nail. So these lesions are actually painful and annoying, and persistent cuticle biting frequently This frequently develops in patients with persistent cuticle bite. So what we do is we trim this with scissors, and we use emollient creams to keep the cuticles. Next is your onychorexis, which may result from frequent soap and water exposure, nail polish remover, hypothyroidism, anorexia or bulimia, or oral retinoid care. Another is your onychoschitia, which is described as splitting of the distal nail plate into layers at the free edge, which is very common among women with dehydration, alopecia, and neurodevelopmental problems. Next is your onycholysis. It is a spontaneous separation of your nail plate, usually beginning at the free margin and progressing proximally. These are usually noted in women, probably secondary to traumatically induced separation, in patients with hand dermatitis, in patients with chronic exposure to irritants and dermatitis, those with secondary infection with your Candida albicans, and systemic diseases such as your hyperthyroidism, pregnancy, pellagra, and syphilis. So for your pincer nails, we also call this as your trumpet nail or your omega nail. And these are seen in patients with trauma, Kawasaki disease, renal disease, lupus erythematosus, or can be secondary to your drugs, especially your adrenergic blockers, etc. So next is your Nico Cryptosis, which is one of the most frequent nail complaints. So we also describe this as ingrown toenail. It usually occurs on your great toes, and it is described as an excessive lateral nail growth into the nail fold, which is painful and an inflammatory condition. Another is your retronychia, which is actually an unusual event associated with your ingrowing of the nail plate into the proximal nail plate. Your retronychia usually induces your chronic paronychia. So in patients with retronychia, nail avulsion is actually curative. Next is we discuss nail diseases. So we just categorize your nail diseases into nail discoloration, nail neoplasms. So for your nail discolorations, so we have your euconychia. So we have 5 forms of euconychia. We have your euconychia punctata, striata, longitudinal euconychia, Eukonychia partialis, and Eukonychia totalis. So, for your Leukonychia punctata, it is actually common in normal persons with normal nails. As for your longitudinal striata or your transverse white parallel lines of your nails, this may be seen in hereditary conditions of traumatic origin or associated with your systemic diseases such as your HIV, Kawasaki, or drugs used in chemotherapy. So for your partial leukonychia, they may occur in patients with tuberculosis, nephritis, complex regional pain syndrome, Hodgkin's disease, chilblains, metastatic carcinoma, and disease. And for your leukonychia totalis, so they may be hereditary or of a simple autosomal dominant type. So they may be associated with your electron beam therapy, your typhoid fever, your Hansen's disease, your cirrhosis, your ulcerative colitis, HIV, nail biting, use of medications, cytostatic agents, and trichinosis. So in general, your leukonychia may result from abnormal keratinization with persistence of your hyaline granules in the lymph node. So for another is your longitudinal leukonychia. So these are longitudinal red bands in nail plate that commence in the matrix and extend to the point of separation of nail plate and nail. So another type of your nail discoloration is your melanonychia, which is your black or brown pigmentation of the normal nail plate. And it is usually seen in patients with malignancy, in trauma, in systemic diseases. Medications can also be seen in patients with lichen planus, fixed drug eruption, and usually, if the pigmentation is over your periinguinal skin, so pag lumalampas siya in this area, we call that your positive Hutchinson sign, which can be a differentiating factor for your nail melanoma. So we also have your pseudo-Hutchinson sign. This is the presence of illusion of pigment in the tissue around the nails. Pero confined pa din siya dun sa area. Hindi siya lumalampas beyond the periinguinal skin. So another type is your green nails, which can be seen in patients with Pseudomonas. And we also have your yellow nail syndrome, which is actually characterized by your marked thickening and yellow to yellowish greenish discoloration of the nails, often associated with your systemic diseases, most often your lymphedema and your pulmonary disease or those with compromised respiration. So for yellow nail syndrome, the nails are typically overcurved both transversely and longitudinally, and they grow very slowly at less than 0.2 millimeters per week, and these patients are actually subject to your onycholysis. So last are your nail neoplasm. So for your benign tumors of the nails, they actually include your verruca, your hygienic granuloma, your fibromas, your myxoid cyst, your Kennan tumors or angiofibromas, your onychopapillomas, and your epidermal cysts. So, in patients with Bowen disease of the nails or your squamous cell carcinoma in situ, imaging may actually show lytic changes. Other nail neoplasm may include your onychopapilloma, which are benign tumors of the nail bed, usually presenting as longitudinal rechonychia, and there is tender swelling of the distal finger with nail distortion and radiographic evidence of your solitary lytic changes caused by your interosseous epidermal cysts. For your onychomatricoma, these are benign tumor of the nail matrix presenting as yellow thickened plate growing out from under the proximal nail toe and then extending distally in a longitudinal band. So there is an increased transverse curvature of the nails, and splinter hemorrhages often are seen in the proximal nail. So it can appear as a cutaneous horn emanating from the proximal nail fold with dorsal pterygium formation. So for your onychomatricoma, your biopsy at the matrix can actually permit your diagnosis. So we are also supposed to discuss on the disorders of the mucous membranes. However, for next meeting, disorders of the mucous membranes, including, I think, yung other topics. So that ends my lecture. So again, gentle reminder, I won't be giving topics that I won't be discussing in your exam. So consider this presentation your outline. However, of course, still a supplement is your textbook as most of your information is in your Andrews. So next meeting will be our last, I think, before our SG.
You're down. You're down. You're down. Shane, you're down. 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 You're down.
So I'd message Dr. China na lang regarding your activity sa SG. So do you have any questions?
Burn.
We have 2 meetings. So if you have no more questions, I think we can end the lecture now. So, okay, thank you. Bye. See you next Monday.